Our next speaker is Dr. Michael Barrington. He's an associate professor from Melbourne and a senior staff anesthesiologist at St. Vincent's Hospital in Melbourne. He's been the associate editor of RAPM, and it's quite an exciting topic that he's speaking about, tips and tricks for teaching and learning regional anesthesia.
Thank you very much, and thank you again for the opportunity to be part of this meeting, and including the rich cultural experience that I enjoyed yesterday. So my topic, tips and tricks for teaching and learning regional anaesthesia. In this presentation, I'm going to be discussing some concepts from the educational literature. I'm going to identify some strategies which I think accelerate learning, and I'm going to list some examples of how long this learning should take. Chris Boddy is a world-class elite jazz musician, a trumpeter. Now, I've had the pleasure of listening to him on a few occasions. And one time I was listening to his performance, and at the end he was acknowledging the skill and expertise of his co-performer, who's an elite, world-class violinist, and he said to her, "We really appreciate the fact that you chose this vocation, musicianship. We're really grateful that you chose this as your profession." But then he corrected himself very quickly and said, "Actually, we're really grateful that your parents chose this as your vocation," because elite performers are often introduced to their future domain of expertise at a very young age. It's often when they're in their childhood that they're introduced to their future domain of expertise, because it takes decades to really reach their peak. There's so many motor skills and cognitive mechanisms that they have to develop to reach their peak. But in our profession, in our domain of expertise, and I'm using regional anaesthesia as the example, we're often not introduced to this domain until we're in our 20s or even later. And by that stage, many of us have excelled in many educational domains. We've excelled at high school, we've done well at university, we've worked hard to get into an anaesthesia training program, and now, as adults, we're being asked to learn and have to put an effort into learning yet another skill. And a lot of adults actually resist this. They don't really want to develop the cognitive mechanisms and the effort required to develop. They don't necessarily want to practice. Professor Chan mentioned that this morning. If we want to develop expertise in point-of-care ultrasound, we have to dedicate the time to practice these skills. So as adults, we're not necessarily as good learners as we were when we were children or younger adults or adolescents. When you have a fellow with you, or registrar, resident, it's good to identify what type of learner they are. Are they a self-directed learner? A self-directed learner is internally motivated. They set academic goals for themselves and they develop strategies to reach those academic goals. Self-directed learners tend to be successful academically and they're internally motivated, whereas externally motivated individuals are really just want to pass the exam, achieve the bare minimum level of competency. The other difference between the traditional, and I'll just pause now to point out what those traditional domains of expertise are. I mentioned music, sport also, ballet, chess, for example. These traditional domains, the highest standard that they can achieve is really what we call a gold standard, whereas research into medical education revolves around achieving the lowest or a minimum level of proficiency required for certification, and so that our doctors can reach a specific milestone. And the other difference between the traditional domains of expertise is the effects of their achievements on others are meaningful, whereas the effects of the achievements of people in our domain, if they have exceedingly high technical expertise, is likely to be minimal. And that's partly because superior technical or superior expert performance in our domain is difficult to be is challenging to make it reproducible, and that's partly because of biologic factors outside our locus of control and other factors. Here's an example of an achievement that's had a meaningful effect on others in the traditional domains. Roger Bannister was the first man to break the 4-minute mile. Prior to this, it was thought impossible that a man could run 1 mile under 4 minutes. And this has had a meaningful effect on others because it's resulted in improved training programs, and this has meant that people, even of lesser ability, have been able to improve their running ability. And this is the same in all sports. What happens when an individual, particularly an adult, is introduced to a new activity or a new motor skill is that they quickly achieve a level of mastery that is considered appropriate by their peers. And they quickly develop a level of automaticity that prevents further learning. So this automaticity is not a good thing because they tend to perform the action in a very unconscious manner. They don't actually pay particular attention to what they are doing. They tend not to reflect. And we see this a lot in the professional domains where people, after reaching a certain level of achievement, their performance tends to plateau and they do not tend to improve their performance despite increasing experience. However, the expert performer develops cognitive mechanisms so that they can have ongoing learning and development. And there are a few things that separate these two individuals, but probably the most significant, these groups of people, the most significant factor is that the expert performer, or the person who desires to be an expert performer, undergoes deliberate practice. And in most domains we can identify the representative tasks that capture the essence of expertise. And I guess we could just go back to sport. I guess a few people in this room would recognise this sport. And there's no question that England and India are probably very motivated to beat Australia in the World Cup. But I'm sure we all understand one of the representative domains of expertise in this sport, and that's simply to make meaningful contact of the ball with the bat so that it doesn't hit the stumps. We all understand that. But for an elite performer in any sport, they have to practice. And what type of practice do they have to engage in? Deliberate practice. If we look at our learners, it would be interesting to know how many opportunities do they actually engage in deliberate practice. If we look at one of the domains for deliberate domains of expertise in ultrasound-guided regional anaesthesia, one of them is the ability to identify the sonographic target, and the other one is to identify the needle in the plane of the ultrasound. But in reality, most of our learners would only practice those skills while they're performing the actual nerve block. This is very different to the elite performer who would practice on many occasions outside of the game environment. This is what we call training, to develop those representative tasks that represent expertise. However, it's worth considering how much time our learners spend developing their ultrasound skills and their needling skills independent of actually performing a nerve block. With deliberate practice, there are rehearsal of specific tasks to mastery, ideally under the eye of a mentor who provides feedback. And feedback is a very important part of learning. They're given a task that ideally exceeds their current skill level. They tend to be motivated to practice extensively and improve. And as I said, they're provided comprehensive and effective feedback, and they're prompted to reflect on their learning experience. So there's three very important words here. There's feedback, they're motivated to practice, and they reflect on their learning experience. How can they do it better next time? Here's an example of deliberate practice. We chose 10 University of Melbourne Doctor of Medicine students, very similar educational background, no experience in ultrasound, and we taught them sonoanatomy of the brachial plexus required for the auxiliary approach, and we identified this as an important representative task, acquiring and interpreting the sonograms, identifying the key anatomical structures. And this is how much time it took. In terms of duration of scanning, 3 hours, feedback, 3/4 of an hour, and didactic learning 1.75 hours. So that's a total of 5.5 hours for these novices in ultrasound to achieve proficiency. And even with 10 practice sessions, they were able to achieve a relatively high level of proficiency. And this is because we're able to provide them a very structured program, and we gave them feedback after each individual scanning session. Now, it's interesting, when we assessed registrars using the same proficiency score, they were nowhere near as proficient. And that's simply because we don't have the resources to provide that same structured training to our registrars. Another core skill is needle guidance. And this can be learnt on a number of models. It need not be learnt with a high fidelity model. It can be learnt with meat phantoms. And this is an important core skill that can be learned outside of the environment of performing the block. So it's equivalent to training for sport. We're learning the core skills off the field. Now, we can learn from cadaver models, and we don't need to use a cadaver, but we can learn and get an estimate of how much practice novices require before they become proficient in maintaining the needle in the plane of the ultrasound. Again, in this project, we provided feedback on quality compromising behaviours after each session, and learning curves were constructed for each individual trainee using QSUM statistics. And what we note here is very representative, that there was a wide level of proficiency in the trainees, and this is something that we have to deal with. We have to acknowledge the fact that our trainees and registrars are going to learn at different rates, and ideally we should have mechanisms that would identify the slow learner early on. And what this trial showed, using a mathematical model, that the average number of sessions required to achieve competency in needle guidance was 28 sessions. Deliberate practice. So to achieve deliberate practice, we need to deconstruct the task. So we've just done that. We've explained how we can deconstruct two of the important tasks for ultrasound-guided regional anaesthesia. We can deconstruct, and the registrars can practice ultrasound skills separate to needling skills. So this is called fractionisation. And then once the learner masters those skills off the field, away from the clinical environment, outside of the operating room, they can then put those skills together and perform the block and ideally be more proficient. And this is called segmentation. Now, another strategy I recommend is what I call the pre-procedure interview, or you could call it the pre-operative briefing. And this is really an assessment of knowledge and judgment of the trainee, and just to get a sense of how they what their vision of the procedure will be. And we developed these questions when we were performing a psychometric analysis of a procedural skill. But these are just an example of questions you can use before the operation. It can be done the day before, if you like. It does not have to be done immediately before the list. And you will be able to unmask various knowledge deficits if you do this. Another strategy that I recommend is that you get your trainees to draw what the intended sonogram is, what the sonogram they hope to capture, and the anatomical relationships. And if you've got a learner who can draw the key structures, I think this really tells you something about their knowledge, and I think this is something that's worth encouraging. The other strategy, and I'm sure many of you do that, and that's providing core knowledge to the doctors before they're starting their regional anaesthesia term, and it also provides an expectation on what that core didactic knowledge is before they come into the operating room to perform the block. And here's an example of, I've pulled apart the sheet, but we've got some what we call quick reviews or quick hits that the trainees can look at before they do the block. It takes about 2 or 3 minutes for them to do that. Again, other questions you can ask in the pre-procedure interview, and again, this is something that will really, I think, accelerate their learning. Another strategy that's important is scaffolding, and it's worth thinking about how much scaffolding you provide to your trainee while they're performing the block. So that's providing, for example, technical support or non-technical support while the trainee is performing the block. Perhaps you're attending to the patient's comfort. Perhaps you are checking the block time out has been done. Perhaps you're giving the patient more sedation, but it's to do with providing support for the trainee. As the trainee becomes more experienced, you can withdraw that level of scaffolding. The learner likely has decreased attentional capacity, and that's because all their efforts are being directed towards those key skills we talked about before. And this is why you need to provide them support and scaffolding so that they can perform the procedure safely and develop. I just want to touch on human performance. Are humans good at assessing the performance of another human being? Well, the answer to that is no. We are not good at that. We vary in the behaviour that we notice. We vary in how we rate those behaviours. We have biases for subjective performance, which may be severe, and rating clinical competency is a significant problem. And so there are a range of tools that can be used for this, and this includes logbooks, direct observation of clinical skills, checklists, global rating scales. I think for regional anaesthesia, a combination of checklists and global rating scales is probably the most valid. This is an example of a DOPS form, which is used for work-based assessment for the Australian and New Zealand College of Anaesthetists. But this primarily assesses, to some degree, knowledge, but more non-technical skills and clinical judgment. It doesn't specifically address technical skills, and therefore you need to use something else for regional anaesthesia, which would include the checklists specific for regional anaesthesia and work-based assessments. It's important to note that these assessment tools are not really assessment of learning. They're not high-stakes assessment. They're really assessment for learning. And it's important that these tools be used to provide structure for feedback to the trainee, and the trainee may be able to provide internal feedback to themselves. They may be able to debrief themselves after a procedure and realise, oh, this is how I can improve. But you may need to give external feedback, and it may just start with an open-ended question. How do you think you performed in that procedure? How do you think everything went? It's important to identify any knowledge deficits, and ideally you make 3 key points. This may include a constructive criticism. This is what you did really well. Identify a weakness. Talk about how further improvement can occur, and provide some positive reinforcement, and ask them again another general question: how was that training session for you? Another important aspect of learning is post-operative rounds, and my trainees, the expectation is that they'll visit their patients doing post-operative rounds to see how the patients are faring. If you don't do that, you will not know how effective these procedures are. You need to visit the patients post-operatively. This should be an essential part of training, and I don't think there should be any excuses for not doing this. You can't rely on third-party reports. Another aspect that's worth thinking about is what level of expertise your trainees are at, and this is given to me courtesy of Graham McLeod, but just knowing what level of expertise they are at will guide you with what educational support that they require. So what does success look like? Well, success would include creating the pre-trained novice, which we've talked about. We'd maximise the procedural learning off the field, outside of the operating room. The learner would develop some type of level of automaticity, and this would free up some attentional capacity as their clinical practice commences. The assessment tools I mentioned are assessment for learning rather than assessment of learning. I recommend that we avoid a coaching culture, and by that I mean through each procedure, coaching them through, talking them through every step, which we can. They need to learn some level of independence. And these are the real things, 2 things I'd like to impart with you. The difference between the everyday performer and the person who desires to be an expert performer is deliberate practice of core skills and feedback. In conclusion, in this educational session, we've talked about the representative tasks that capture the essence of expertise. We've talked about off-field or out-of-operation room strategies to accelerate learning. We've talked about pre-procedural interview and briefing. We've talked about how to set core knowledge expectations, and we've talked about the importance of post-operative rounds. Thank you once again for your attention.